You're listening to Treating Blood Cancers, the LLS podcast series for professionals. We will be joined by cancer experts to discuss blood cancer diagnosis, treatment, side effects management, and the importance of clinical trials. They will share their experience in treating patients and discuss strategies for optimal patient care. Let's get the conversation started.
Welcome to Treating Blood Cancers, the LLS podcast series for healthcare professionals. I'm Dr. Ken Miller. I'm a medical oncologist and an LLS volunteer. And I want to thank all of you for joining us on this episode today. We have a great topic to talk about, which is CLL. And we're delighted to be joined by Dr. Kerry Rogers, who's an associate professor in the Division of Hematology at The Ohio State University. She specializes in CLL. Kerry, thanks for joining us.
Well, thanks for having me. I'm really excited to be here.
So I have to say, I'm a generalist. I've done pretty much everything in my career. But I have to say, CLL I've always found to be particularly interesting for a lot of reasons. One is that we tell patients, you have leukemia, and often I don't want to do anything about it. So I just find that sort of just an interesting dichotomy. Let me just ask you, what made you interested in CLL?
That is an excellent question. I thought it was a really interesting disease. And of course, I was really focused on kind of hematology more than solid tumor oncology to begin with, just in terms of things that I liked. But what I thought was really cool about it is just all the neat new therapies we had for people. And also that a good amount of time was devoted to trying to have people that have leukemia understand that they're pretty well and can go about their business and do things they like to do. And I really liked being in a space within malignant hematology where instead of telling people that their life needs to be more restricted, most of the time I'm just trying to convince people that they are well and should go about their business and do the things they want to do. And I spend more time doing that than probably anything else, whether people need just observation because they don't need treatment right now, or whether they do need treatment. You try to fit this into their lifestyle as best as you can. But you do still have some people that are greatly impacted by this, that are really sick from it or need to start treatment that really detracts from their lifestyle temporarily. So you still do have people, and especially as a complication, people with Richter's syndrome, which is an aggressive lymphoma, and someone with CLL. So you get people that are really sick and do need a lot of those things, but you get a nice group of people who your main goal is try to maintain their current health and functioning. And I like that because it's kind of a bit different than some more aggressive forms of cancer or even like curable types of cancer where the treatment's really intensive. That really is kind of nice, especially with the targeted agents. And then I just thought the research going on in CLL, especially on newer therapies, was really cool and could really see what a direct impact that was having on people's lives. So that's kind of how I got interested in it.
Yeah, and I have to say, I can hear the enthusiasm about it. It's really a great field. I'd love to start with just a very basic biology question. You know, we think about B cells in general and the spectrum of the maturation process and where different diseases can emerge. If you would give us an overview of where CLL fits into that spectrum of B cell diseases. And also, it's sort of a second question, but what are some of the differences between CLL and SLL and some of the forms of non-Hodgkin's lymphoma?
Yeah. So CLL is a cancer of B lymphocytes. That's kind of like the cell of origin. And everybody knows there's a very wide spectrum of cancers of B lymphocytes. CLL is really on the more chronic or indolent scale there. So thinking of something like BALL as being like the most aggressive type of B cell cancers, this is really one of the more indolent ones. And, even though you see that patients can have a bulk of these cells in their lymph nodes or in their blood, it doesn't really cause a lot of tissue disruption, inflammation, or damage to things. And people can actually live with the existence of these cells quite nicely, which is really very different than things like diffuse large B cell lymphoma. So this is really on the indolent side. And then, of course, like anything, CLL within it has kind of a spectrum of manifestations. So CLL cells are B cells that have a specific immunophenotype and biologic features. And we know that if there's less than 5,000 per microliter in the blood of these B cells, the clonal like CLL cells, and they don't cause any problems anywhere, we call that MBL. That would be usually a high count CLL like MBL, where you can tell the lymphocyte count's elevated, but it's not above 5,000 clonal and it's not causing problems. So that's monoclonal B lymphocytosis, or MBL. You can think of it like the MGUS of CLL, with about a 1% per year risk of progressing to CLL needing treatment. Then you've got CLL, which just means that there's more than 5,000 of these clonal B cells per microliter. Technically, that has to persist for 3 months. And that's just because some of these cells marginate due to infection and go back into the tissues. So we don't call it CLL just because it's over 5,000 just once. However, if someone has 100,000 of these cells in their blood, I think you can feel fairly confident that's CLL and just move forward. And then there's SLL, where the cells are causing problems. These CLL cells are causing problems, but it's just not circulating very much. So enlarged lymph nodes, enlarged spleen, things like that, but not as much circulating in the blood. Interestingly, in 2018, the update to the IWCLL, or International Workshop on Chronic Lymphocytic Leukemia guidelines, which were published in Blood, defined that if you have marrow infiltration causing cytopenias, that even if you don't have 5,000 clonal B lymphocytes per microliter of blood, it's classified as CLL, I think, because it just infiltrated the bone marrow so heavily. The difference between CLL and SLL is really, I think, just to confuse everybody. It's kind of
Okay.
semantics. Biologically, these cells are the same. The features of them that we use to stratify risk in terms of risk of progression, need for treatment, and also the response to therapy is the same. Treatments are the same. So it's really biologically very similar. One of them just doesn't circulate, so we call it SLL. And then, of course, within that, you have people that really have CLL or SLL that for decades never causes them any problems, and then some people who do get sick of it in a shorter time frame. So even though it's one of the more chronic B cell malignancies, for some individuals it can be on the more aggressive side of that spectrum or more problematic.
Another two-part question, but what are the risk factors for someone getting CLL? The other thing that's always I found very interesting, what are some of the risk factors for progressing? I think each of us in practice have patients who just have never progressed, and then we have others that do. So how can you predict?
Yeah. So, in terms of risk factors for getting CLL, I think age is probably the big one. I was talking a little bit about high count MBL, which is like the pre-leukemic condition where you have usually enough cells to increase lymphocyte count. But there's low count MBL where you have less than 500 cells per microliter of CLL cells. Mayo Clinic did a very nice series on this. The incidence of these CLL cells existing anywhere in the body, including at these low levels, increases with age quite substantially. And the median age of diagnosis of CLL is 70. So I think some of this is just kind of the biochemistry is as B lymphocytes replicate, you end up getting these ways they break and become CLL cells or pre-CLL cells. So I think that is actually a risk factor no one talks about much, and you do not see CLL in children. The youngest I've seen is 24. Other risk factors, family history is a risk factor. So CLL does run in families, despite the fact that we've not been able to identify one gene that transmits it, kind of like you think breast cancer with BRCA. There's nothing like that. But having a family member, a first degree relative with CLL, does increase the risk of actually the whole spectrum of those diseases, MBL, SLL, and CLL, and within the different risk categories of CLL, which I'm about to talk about in a second. And then I think a lot of the things that increase risk for B cell cancers in general, like pesticide exposures, probably increase the risk of CLL. But I haven't really delved into that much myself, so I try to stay out of describing that area in a lot of detail. So that's kind of risk for why someone might develop CLL. And again, this is just like risk features. It's not a guarantee that someone will develop it.
Right.
Within the biologic features of CLL, there's three different categories of biology that we look at to try to get an idea if someone's CLL will be more or less aggressive. The one that actually is coming out as having potentially the most predictive information is something called IGHV mutational status, or immune globulin heavy chain gene variable region mutational status. And what it is, for anyone that doesn't really delve into B cell biology that much, is that mutated is actually the more mature or developed normal state. So B cells undergo a normal process of somatic hypermutation to mutate their immune globulin genes as a part of their normal maturation. So unmutated means that they did not undergo that normal process to mutate their immune globulin genes. Mutated means that they did, and that their immune globulin heavy chain gene is more than 2% different from the original germline copy. So that is a more mature CLL. Some people say that unmutated is like high risk. The way I think about it is unmutated is kind of like regular risk, and mutated IgHV is kind of like low risk or special low risk feature. But if you look at time to treatment, it's longer for people that are time to first treatment, longer for people IgHV mutated. Progression-free survival with most therapies is longer. There's some really neat things that we don't talk about too much anymore, but FCR chemotherapy might even cure some of those patients. We don't use that anymore for a variety of other reasons, but that's one really important prognostic feature. And the other ones are chromosomes. So there's karyotype, which is, of course, all the chromosomes, and people with 3 or more, and definitely with 5 or more independent chromosome changes, it's called complex or highly complex karyotype, really have a higher risk of needing treatment and progressing on treatments. And that's been seen across a variety of treatment settings. And then there's a FISH panel to look at select chromosome changes, including deletion 13q, trisomy 12, deletion 11q, and deletion 17p. 13q is the lowest risk, 17p is the highest risk. It removes the TP53 gene and probably some other things by missing that part of that chromosome that matter. Deletion 17p in the chromosomes predict kind of the shorter time to needing treatment, and actually responses to chemoimmunotherapy were very poor with those patients. Fortunately, with our new targeted agents, people with deletion 17p CLL actually can do much better. And then, kind of the last thing that's a more newer area to look at is actually mutations. So, of course, you look at IgHV mutational status, which is a normal mutational process, and whether or not it's occurred. Chromosome changes or cytogenetics, and then mutation changes. TP53 mutation is kind of the big one, because even if one copy of TP53 is deleted with deletion 17p, then you might see the other copies mutated. It seems like mutations in TP53 carry the same adverse prognostic features as having a deletion 17p, so that is very important to test for. There's other mutations that can have prognostic significance too. The IgHV mutational status never changes in the CLL clone, but the chromosome changes and mutations, you can develop new ones the longer people have had CLL. So I do recommend retesting for those if something changes with the CLL or a new treatment is planned.
So, Carrie, I'd love to drill down a little bit, and I'll try to use some examples because I just find this, just the clinical practice of oncology so interesting, and particularly with patients with CLL. Patient that I followed for 19 years, he had CLL, still has it, but white count about 18,000. And it was 18, 18, 18, just years, maybe 19. It never really changed. And to the point that I said, Mark, I'm really hopeful this won't change. Well, sure enough, the 20th year, all of a sudden he developed hemolytic anemia and his white count went way up to like 50,000, and he required treatment. Now, to be honest, we did not find, when I sort of looked at a prognostic panel before and after all this, really nothing changed. So, what's your sense of what changes in the biology and why after so many years?
I mean, my guess would be that the CLL clone had picked up a new driver mutation. There are more of them, and we have a 50 gene NGS panel, which picks up a lot of mutations. Not a lot of people are able to get that test. But even so, there could be mutations that result in that change that just aren't looked for with, our standard cytogenetic or mutation panels that we do. So my guess would be something like the way I describe it to patients is broke further in the CLL clone, but it really acquired a new mutation. And I think what happens is just as the CLL cells divide, they just make more errors. And if they're broken, they're more prone to doing that. And that's why you see that change.
Right. Purely anecdote, but again, this whole issue of watch and wait, in terms of your clinical experience, what's the longest you've had a patient on watch and wait?
That is an excellent question. So I would say that these aren't even patients that saw me originally at diagnosis. They're patients where I'm like their third hematologist because people keep retiring on them. And you're talking about 20, 30 years and never needing treatment and having usually about the same lymphocyte count. So I think you just get some of these CLL clones. It's CLL, but it's just very indolent. And that doesn't mean that they can't either acquire change in it and that it would become more proliferative or something will change in it at some point. And then, as you pointed out, there's some complications such as autoimmune hemolytic anemia that are common, even if the CLL isn't really progressing. That's a good reason that I do keep seeing these people for annual follow up. But after 20 years of nothing changing, I don't really think it's necessary to come more than once a year, if you know what I'm saying.
Yes, yeah, absolutely. One of my personal few contributions to the oncology literature was an article on use of the word cure in cancer care. And let me ask you about that with CLL. We were essentially taught a CLL was not a curable disease. So let me ask that to you. Is CLL a curable disease?
So the standard thing to say is no, and that in the majority of cases, we don't consider it curable with standard therapies. Some of it does depend on how you define cure, and there are a couple exceptions to CLL not being curable as a general rule. One of those exceptions is that patients with IGHV mutated CLL, that we would guess those that don't have deletion 17p or TP53 mutation, can get a regimen called FCR, and there's follow up showing that at 10 to 12 years after that treatment, a good number still have no detectable circulating CLL. So I would predict that those patients would finish their natural lifespan and never have recurrence of CLL again. And I would consider that a cure if you finish your
Yeah,
whole lifespan and never have disease recurrence.
yeah,
So most people in the field agree that's a cure. We don't recommend that treatment anymore for a couple of reasons. One is the risk of getting a second, actually myeloid cancer like a therapy related MDS or AML is pretty high. I think depending on which follow-up you're looking at, it's around 5% for those combined. And then actually the randomized comparison of ibrutinib rituximab to FCR in younger individuals showed that in IGHV mutated CLL patients, the progression-free survival is actually better with ibrutinib rituximab, even though you're theoretically curing some of those patients. That study was not powered to show that. It was an exploratory analysis, but that was statistically significant. So when you're looking at that, I don't think there's a lot of reasons to proceed with FCR, but that is a caveat there. And then the thing that might be a cure, but I think there's a ways to go before we really say that for sure, is cellular therapies such as CAR T cell therapy. But I have a couple of patients who got that on clinical trials that are, I think, 7 or 8 years now from having gotten that and have not had their CLL return. So you think maybe that's a cure. And then traditionally, a donor stem cell transplant or allo transplant would be curable for CLL, but it's not often done because people's morbidity or burden of healthcare and potentially survival in many cases would be shortened by
yeah.
doing that compared to standard care. So I tell patients CLL is curable. I don't consider it curable, but there are those like few instances where you say, okay, maybe in those cases it would be.
Yeah. I have to say, it's been very exciting. Exactly what you brought up earlier with all the new drugs. Give us a short tour of the therapies that are available. And then after you do that, then I've got some questions about what's next.
Yeah. So I'll just talk about it usually as like people experiencing a first treatment because what to do after that, I think, becomes clear depending on what people got as a first treatment. And also, I think the field has to sort out a little bit more about what to do in terms of taking these treatments in order. But the two major classes of drugs that are dominantly used to treat CLL, both are combined with anti CD20 antibodies, which have been used in combination with chemotherapy and used as a monotherapy don't result in really durable remissions. But the two major classes of drugs are targeted agents. So there's inhibitors of BTK, which is in the B cell receptor signaling cascade. So the three that are approved covalent BTK inhibitors are ibrutinib, which is the first in class but has the most cardiovascular side effects, and then acalabrutinib and zanubrutinib. They all bind BTK covalently and irreversibly. They all have some degree of side effects, and it is likely that resistance mechanisms between them are shared. And it seems to be the case in most cases that resistance to one means resistance to all three in terms of the CLL. I'm sure there must be a rare exception out there somewhere, but that seems to be the case. There's some finer points on the differences between them in terms of side effects, and like obinutuzumab, an anti-CD20, is approved with acalabrutinib as a first therapy, and that combination has an improved progression-free survival in patients that don't have deletion 17p in their CLL. So that's kind of one class of drugs. They're approved as initial therapy. They're approved, of course, as a subsequent therapy, but they are taken indefinitely until either intolerance develops or the CLL progresses while people are on therapy. So treating until progression generally means that the CLL clone is then resistant to the 3 covalent BTK inhibitors. There is a non-covalent BTK inhibitor, pirtobrutinib, which is approved only in the previously treated setting with both BTK inhibitors and with the other class of drugs, which right now is venetoclax. So that is a different thing, and I wouldn't mix that up with like the first-line BTK inhibitors, but the target
Okay.
is the same. The other class of drugs is BCL2 inhibitors. The only one approved currently is venetoclax. So that actually blocks an anti-cell death protein and results in very rapid cell death. And the major issue with using the drug is actually the risk of hyperacute tumor lysis syndrome. As we were saying, people live with CLL a long time and can have a high disease burden. So it requires a rather annoying ramp up and monitoring scheme that usually does not result in harm to patients, but is very administratively challenging for patients and a lot of practices, not mine. I work at a big academic center, but in smaller practices, it's a real challenge. And that's usually given with obinutuzumab for a 1-year treatment in the first line setting and with rituximab for 2 years in a relapsed refractory setting. And I think the most exciting thing that's kind of happening now in terms of using these current classes of drugs are combinations of BTK inhibitors and venetoclax and some newer BCL2 inhibitors like sonrotoclax, which is in currently phase 3 trials, to try to do a fixed duration treatment. BTK inhibitors are continuous, venetoclax is fixed duration. The combinations are usually fixed duration and have really nice results. So I think that's kind of one of the coming attractions. And then there's a variety of new targets for patients whose CLL has become resistant to our standard therapies.
Out of interest, what are some of the targeted therapies that we should be looking for?
The one that just got approved, pirtobrutinib, actually has nice results, and that's a BTK inhibitor, but I think people should probably realize that that's a different type of BTK inhibitor, so it's a non-covalent one, binds at a different site than the other three. It has accelerated approval in the covalent BTK inhibitor and post-venetoclax setting. So it's not a different target, but it's kind of a different way of targeting BTK. And then there's BTK degraders, which actually wholesale just use the cell's kind of protein destruction machinery to remove BTK from cells. Those are neat. They're in testing across a variety of B cell cancers. So it's not really a new target, but it's a very new mechanism. And I look forward to seeing where that goes. Currently, it's benefiting people in clinical trials whose CLL is resistant to other therapies. So we've seen some results, but it's still kind of earlier phase. And then there are other new BCL2 inhibitors in development too, like sonrotoclax, which I mentioned. And new targets, we really do need some. I think we found 2 really great targets, and then everyone got really excited to just target those better or use combinations of those drugs better. We had a PKC beta inhibitor in testing here, which had nice results. So I think it is important to continue to explore new targets because certainly, as we just said, the available drugs don't really cure people. The one thing that I think is really exciting is actually moving from targeted agents into immunotherapies. So if you do any general practice oncology, you know that immune checkpoint inhibitors were very exciting and had a big impact on treatment of mostly solid tumors and
Yeah,
some lymphomas. Yeah, right. But those didn't work at all in CLL, right?
right.
Yeah. So we got left out of that party. And CAR T also was tested really early in CLL, but didn't get accelerated approval until late because it actually doesn't work super well. So only about 1 out of 5 patients get the result we all want out of CAR T, which is long-term disease-free survival for years. And so, that's another immunotherapy that doesn't work really well, but I think that strategy is really exciting. So I look forward to seeing that improve because when you give targeted drugs, the CLL cells eventually become resistant in most cases. And so using the immune system to target the cells is a better strategy in many ways. And then actually bispecific antibodies, which are approved in some B-cell lymphomas, are now being tested in CLL. And I really look forward to seeing how that turns out. I think that's something that has the potential to be very helpful for a lot of our patients.
We have so many different therapies. How do you decide who gets 2 drugs, who gets 3 drugs, who gets 1 drug? Yeah, what's the thinking process?
Yeah, that's a good question. Also, which drugs, since there's 2
Yes, yes.
dominant classes. I like to think of it kind of in steps. One is one of these classes is going to be best for that particular person's CLL. So, for example, patients with deletion 17p or TP53 mutated CLL have a similar progression free survival with continuous BTK inhibitors as those that don't have that high risk feature. In other settings with other treatments, the progression free survival for patients with a deletion 17p is universally shorter. So, for people in that group, if patients want to maximize their benefit from initial therapy, then I suggest BTK inhibitors. This is in the first line setting. Obviously, if patient CLL is resistant to one of the drugs, that changes things. So you just think like, hey, is there something about this person's CLL that makes one of these options better? In fact, in patients with IGHV mutated low risk CLL, you see really good progression free survival with venetoclax and obinutuzumab. So you start to think like, hey, maybe the recommendation should be to do a fixed duration 1 year treatment and expect really good results. So I do kind of think about what features of the CLL might help us select this a little bit. Then you kind of get everybody in the middle that either would be fine and you'd expect similar results. And I think about, does this person have any health conditions that would make one of these treatments a really bad idea? So, say you have a patient who has atrial fibrillation that's like ruining their life, right? Symptomatic, hospitalized for it, has ablations. You probably don't want to do BTK inhibitors because even the newer ones that have less AFib still have some of that risk. And you don't want to make someone's life worse by giving them a medication that has a side effect that would interact very badly with the kind of their baseline AFib and health state. Or if someone's on like warfarin and dual antiplatelet therapy and has a lot of bleeding problems, BTK inhibitors would not be the way to go. And then similar for venetoclax, if people have really poor renal function or don't tolerate hydration well, that's going to be really hard for the ramp up on that one. So I probably wouldn't do venetoclax. So I kind of think about like what might be good for their CLL, what might be a non-starter in terms of their other health conditions or make something unduly risky. Then I kind of ask the patient a little bit about what is feasible for them. I have some patients that are really motivated to do a 1 year treatment scheme and come to clinic 1 to 2 days a week to start Ven-Oben because it's like 3 weeks of Oben, 5 weeks of Ven. And they're like, oh no, that's totally fine. But I'm so happy to do this for 1 year. And then you have some patients who really will not. So we get a lot of people from surrounding rural communities where it takes a lot of effort for them to come here. It's not feasible for them to come for a ramp up or infusions unless they really have to because it's really just a high burden on them. And so I have many patients that just prefer BTK inhibitors for their convenience, and that's not a wrong thing. I also usually offer people clinical trials, and many people are excited to do that, but that's a whole different discussion, and I know not everywhere gets to offer those.
Excellent. How about side effects? What are the more common things you see in treating patients with CLL? And to say a little bit, if you would, about side effect management, the team approach there.
Yeah. So I do think the side effects with the current targeted agents are very different than what you might expect from cytotoxics. I like to tell patients that most people live with some mild chronic side effects that don't keep them from living their lives or doing what they want to do for the most part, but are just different. Things like extra bruising, nail changes, maybe some more joint pain or looser stools. And I do get patients with some of these side effects that we offer suggestions for making it better or supportive care. And they're like, oh, I could, but I'm totally fine with this. I don't want to go try something else for it. Like, I'm all good with this. And I think that's fine. There are some patients that have almost no side effects from these targeted drugs, and in those cases, that's great. So there's really nothing to worry about. And patients with severe side effects, in general, if it's really intolerable, we do switch to a different drug, either a different BTK inhibitor, if they're on a BTK inhibitor, a different class of medication. We don't usually have to, especially in the initial treatment setting, get people through really awful side effects. Some of the things that people find really problematic about BTK inhibitors, like heartburn, headaches, or joint pain, do get better a few months into treatment. So we do try to coach people through that. And this definitely is a good team approach. I'm very fortunate to work with a good team of providers that take care of people with CLL. We have like a nursing team and then also nurse practitioners and PAs. So our APPs actually do a great job with side effect management, including they have like some electrolyte supplement that seems to be helping a lot of people with muscle cramps. And they, of course, have a lot of experience taking care of people taking these particular targeted drugs. And, even in clinical trials when we had them investigationally. So that's like a huge resource for the patients too.
Got it. Carrie, I'm going to ask you also about resources. Any particular resources that you would recommend for patients?
I think like what resources patients are interested in really depends on who they are as a person. As we were saying, a lot of people are on observation and they don't want to know anything else about it. And they're like, I'll do what you say, but I'm just going to put my fingers in my ears when I leave here, and I'll come back when you said, and I'll call you if I think something's wrong. And I think that's fine. But there's a lot of people living with CLL and living very well and feeling well, and they like to talk to each other. So there's a lot of communities, especially online. I have a couple of patients that have joined like Facebook groups for this, and many of them find that beneficial. They hear things from each other that they ask me about, which I think is really nice. And fortunately, in 2024, I think most people at least know what the weird part of the internet is. So I tell people just to stay away from the weird part of the internet. There are, of course, patient education and advocacy groups that do a lot of work. Leukemia Lymphoma Society actually makes the educational handouts that we have for my clinic, and they have a lot of resources for patients, including some that might help with more practical things like financial support for people dealing with cancer treatment and certainly education. The other two education and advocacy groups I've worked with quite a bit would be Patient Power, which does a lot of baseline disease state education, and then CLL Society, which I think does a very nice job of educating patients on cutting edge therapies. I mean, they do general education too, but I think they really keep up with some of the cutting edge research in CLL and focus on that as an educational effort. So those are just some of the usual ones, but I've had patients that found community support groups helpful and other things. So I think it's really what matters for them or what helped them as a person with this.
How about financial toxicity?
Yeah, so financial concerns are very, very real. Even an observation, there's a cost for many people to come for visits and get blood draws and things. Most people with decent health insurance find that part at least okay. Then you got to take into account things that we don't think about when we think about cost of healthcare, which is the cost of traveling maybe to see me, which can be an hour having to buy lunch out, staying in town overnight if you're doing treatment, or if you're coming the night before a visit because you don't like to drive in the pitch black. So these are things that have a real cost. And then treatment, of course, has costs associated with it. Even when it's covered by insurance, there are people with very high deductible plans. Even like health insurance deductibles, which you would easily meet taking any sort of treatment, can be unaffordable for people.
Yeah.
And then I think something that is a big source of, at least I hear and I understand why, or can imagine why, a source of concern for patients are these oral targeted agents go through a prescription drug benefit. Even people with commercial insurance copay for an FDA approved drug like zanubrutinib might be $10, could be $700 a month.
Yeah.
And so that's really problematic. And then people worry, if my job changes, if my wife's job changes, if my insurance changes, if I go on Medicare, how will I keep getting this drug that I need that's working for me, that I'm tolerating? How will I get that covered? And I think that is huge. And even people that are getting support for it or have good coverage for it know that these drugs cost like $20,000 a month. And just knowing that is very difficult for people.
Sure is. All right. Again, this is Dr. Ken Miller, and I am a oncologist, hematologist, and an LLS volunteer. And I want to thank all of you for listening to this terrific episode on CLL. I particularly want to thank Dr. Kerry Rogers from the University of Ohio Cancer Center. Kerry, this has been a terrific review of CLL, so thank you so much.
Well, thanks for having me.
For a listing of all of our healthcare professional continuing education activities, podcasts, and healthcare professional resources, including a fact sheet and recorded webinar on CLL, please visit lls.org/CE. And for any questions or to refer a patient to LLS, please contact our Information Resource Center by calling 800-955-4572. Information specialists provide personalized one-on-one support to help patients learn about their disease treatment, financial, and support resources. LLS also provides other resources for patients, survivors, and their families, including a series of podcasts that can be found at lls.org/support. And I encourage you to sign up to receive notifications of future podcast episodes by subscribing at treatingbloodcancers.org. We look forward to you joining us on future episodes.
Thanks for listening to Treating Blood Cancers, the LLS podcast series for professionals. We can be found on iTunes and other podcatchers. You can subscribe at www.treatingbloodcancers.org and provide your suggestions for future topics. Visit our archives section on our website for other great podcasts. Be sure to rate and review us on iTunes. Keep up with LLS by following us on Twitter at LLSUSA and on Facebook at the Leukemia and Lymphoma Society. And access our professional continuing education activities by visiting lls.org/CE. Let's keep the conversation going. Until next time.